All right, so you're an endocrinologist, and a pituitary MRI lands on your desk. It can be like looking at a tiny, complex puzzle, right? The signals are so subtle, the anatomy is all packed in there, and honestly, the stakes are super high. Well, today, we're going to hand you the cheat codes. This is a practical, step-by-step guide to reading these scans. We'll cover everything from the basic imaging protocols right up to using population-specific data to really lock in that diagnosis. Okay, let's get into it.
So here's our game plan. We'll kick things off with the MRI protocol essentials. Then we'll get our bearings by navigating the cellar anatomy. After that, we'll figure out what a normal gland looks and feels like so we can then decode pituitary lesions. Next, we'll look at how population-specific data can be a real game changer. And we'll wrap it all up with some key clinical recommendations you can take with you.
All right, first things first, the MRI protocol essentials. We're talking T1, T2, flare. What does it all mean? Look, there's a reason MRI is the gold standard here. It's just unmatched in its ability to pick out those tiny, subtle problems in soft tissue. But, having the tool's one thing. Knowing which setting to use and why, that's where the magic happens. Okay, think of this table as your essential toolkit, right? Each sequence is like a different lens on your camera. So T2 is your go-to for anything cystic. Think Rathke's cleft cysts, because it makes anything with a lot of water in it light up bright. T1, on the other hand, gives you that gorgeous structural detail for solid tumors or even hemorrhage. And post-contrast T1, that's the secret weapon. It's how you spot those really subtle microadenomas. They typically show up as hypointense, which just means they look darker than the rest of the normal gland, which really lights up with the contrast. But here's a really critical point. For those super small, hard-to-see lesions, just a single post-contrast image might not cut it. This is where dynamic contrast-enhanced MRI, or DCE, comes in. It's a game changer. Basically, you're taking pictures every few seconds right after injecting the contrast. And what this does is it captures the timing of how things light up. A less vascular microadenoma will enhance much slower than the supervascular normal gland. And that difference in timing makes the tumor just pop right out. Okay, so we've got our tools. Now let's take a tour of the neighborhood we're actually looking at. The cellar anatomy. I mean, you've got to know your landmarks, right? Getting this part down is the absolute foundation for any accurate read. So here in the sagittal view, we're seeing the gland in profile. It's perfect. You can easily tell the anterior from the posterior pituitary. But what you really want to pay attention to is the pituitary stalk. It should be straight up and down, right in the midline, coming down from the hypothalamus. No exceptions. And then we have the coronal view. Honestly, this is the money shot, especially for checking out mass effect. You're looking up superiorly to see if anything is pushing on the optic chiasm. That's a huge deal, obviously. And then you look to the sides, laterally, to check out the cavernous sinuses. You're hunting for any sign that a tumor might be invading that space. Now, here's a fantastic little diagnostic tip. Sometimes before you can even clearly see a mass inside the gland, the pituitary stalk will give it away. A deviated stalk is a huge, huge clue. Think about it. A mass is going to push the stalk away from it. So if you see the stalk pushed over to the right, you better be squinting really hard at the left side of the gland for a hidden lesion. Okay, let's switch gears and talk about what's normal. So what is a normal gland supposed to look like? Well, it's tricky. The pituitary isn't static. It's a dynamic organ. Its size and shape can change, sometimes dramatically, depending on a person's age, their sex, and their hormonal status. A really good place to start is with a simple rule of thumb called Ulster's rule. It's just 6, 8, 10, and 12. This gives you a quick and dirty guideline for the maximum pituitary height. 6 millimeters for kids, 8 for adult men, 10 for young women, and up to 12 during pregnancy. It's just a great little sanity check to have in your back pocket when you first look at a scan. But it's not just about height. Shape is absolutely critical. You've basically got 3 common shapes: flat, convex, and concave. And you really evaluate this on the mid-sagittal T1 images. Now, a nice, plump, convex shape on top, totally normal for a younger person or during pregnancy. But that same convex shape in an older guy? That could actually be a microadenoma in disguise. As people get older, a flat or even concave shape becomes much more common. So you see, context is everything. All right, so now that we have a good feel for what's normal in terms of anatomy, size, and shape, let's get into the good stuff. Decoding pituitary lesions. We'll look at everything from adenomas to cavernous sinus invasion. So, when it comes to adenomas, the first big distinction is super simple. 1 centimeter. That's the magic number. If it's smaller than that, we call it a microadenoma. Bigger, it's a macroadenoma. And it's these macroadenomas that are big enough to really start causing problems, that mass effect. As they grow upwards, they get squeezed by the diaphragma sella, and that creates this classic snowman or figure of eight look. It's pretty unmistakable when you see it. Okay, when you're dealing with a macroadenoma, one of the most important questions for the surgeon is, has it invaded the cavernous sinus? And for that, the Knopf's classification is your go-to tool. It's a really clever grading system, from 0 to 4, that helps predict the chances of invasion, all based on how the tumor is positioned next to the internal carotid arteries. The way it works is actually pretty elegant. You just look at where the tumor is in relation to the internal carotid arteries. So a grade 1 means there's about a 25% chance of invasion. Grade 2, that jumps to 50%. Grade 3, you're looking at a 75% likelihood. And if you see a grade 4, where the tumor has completely wrapped itself around that artery, well, that's a 100% chance of invasion. And you can bet the surgeon wants to know that before they go in. Now, it's super important to remember, not every lump and bump in the sella is an adenoma. You've got to keep your differential diagnosis wide open. You could be looking at a Rathke's cleft cyst, which is often cystic, or maybe a craniopharyngioma, which can have both cystic bits and calcification. And you have to be on the lookout for inflammatory conditions that can fool you. Things like lymphocytic hypophysitis, which is inflammatory and often pops up in postpartum women, or even rarer stuff like histiocytosis or granulomatosis. These can look like tumors, but there's something else entirely. So those general rules of thumb are great, but what if we could get even more precise? Well, this is where it gets really interesting. A study looking at the Kashmiri population highlights why having population-specific data isn't just an academic exercise. It's absolutely crucial for getting the diagnosis right. Check this out. The very first finding from this study kind of turns what we thought we knew on its head. We just said that a convex gland is pretty common in younger adults, right? Well, in the Kashmiri population, the single most common shape, found in 58% of people, was flat. That's a huge deal. It completely changes your baseline for what you should expect to see as normal in this group. And it didn't stop with shape. The study gave us some really specific numbers for pituitary height. So for kids aged 1 to 10, the mean height was 5.6 millimeters. That was the lowest value they saw. Then it peaked in young adulthood for the 21 to 30 crowd at 6.8 millimeters. After that, it starts to gradually come down in folks over 50. See how having these exact numbers gives you a much sharper definition of normal than just a general rule? And what about volume? This is where you can really see the impact of hormones. If you look at that same 21 to 30-year-old group, the women had a noticeably larger mean pituitary volume than the men. We're talking 452 cubic millimeters compared to 417. This isn't just a vague idea. This is data that actually quantifies that physiological growth we expect to see in young women. And this quote from the study really nails it. It says, "A complete knowledge of physiological variation is necessary to assess abnormalities. A systematic approach is very important because sometimes findings are very subtle." And that's the whole point, right? When you have these specific baseline numbers, you can look at those borderline cases with so much more confidence. It takes you from saying, it looks a little big maybe, to making an objective, data-driven call, and that's so important when the findings are subtle. Okay, so let's bring it all home. What are the key takeaways you can actually put into practice? Let's boil it all down. All right, here's your checklist. Number 1, always push for a small field of view, or FOV, to get those beautiful high-res images. 2, be systematic every single time. Check the stalk, check the chiasm, check the sinuses. 3, use the Knopp score to evaluate that cavernous sinus invasion. 4, if you can, get your hands on population-specific data. And number 5, and this is the big one, if you're looking at a gland and you think, this is kind of borderline weird in size or shape, your next move should be a dynamic contrast study. That's the tiebreaker. So I'll leave you with this question to think about. With this kind of population-specific data, just how many of those borderline cases could we confidently reclassify as normal? I mean, this isn't just about being a better radiologist or an endocrinologist. This is about potentially saving patients from anxiety, from unnecessary follow-up scans, and from interventions they might not even need. It really just shows you the power of good data to make us better clinicians.